Well, our guest today needs no introduction. He's a doctor, pediatrician, international breastfeeding expert, author, speaker, and an incredible human being. Welcome, welcome, Dr. Jack Newman.
Thank you very much, Daniela.
And I wanted to start by telling these stories about my experience interacting with you. And the first story goes back to 2015. It was the Congress of Pediatrics here in Nuevo León. You probably won't remember, but when I first met you, as I was speaking to you, I remember I said, I'm just a breastfeeding counselor. And I will never forget that you replied with a question. Oh, really? Just? As if saying you should really rethink the value you're appointing to the work you do as a breastfeeding counselor. Well, at least that is what I thought back then. And then you were so warm, so willing to talk and to teach and to even take pictures, which I have. And so the second story, or what really follows, is me writing mails to you to ask breastfeeding questions. I really didn't. I didn't think, not that you wouldn't answer, but never thought you would reply so fast and so well and thorough. And it wasn't just luck because it happened consistently each and every time I wrote to you. And you know what? What came up to me in those interactions was your humanness, the way you interact from the human to human level, how you really want to contribute and help and serve. And I really wanted to say this to you, and I hope I'm not being too much or, making you uncomfortable. But
Not at all. I like to hear it.
I really think it's so beautiful. It's beautiful being the figure that you are, that you are in the breastfeeding world, that you are this way. And so thank you for your humanity and your kindness, Dr. Jack.
Okay,
And well,
thank you very much, Daniela.
finally, just a little before we start our subject, our topic of today, I think there's a place for protocol and formality, of course, but I also think that when you're trying to connect person to person, it could sometimes act as a barrier, formality, I mean, and I really think you understand that perfectly. I love that you sign your mails just by your name, Jack. Can I call you Jack today?
Sure, of course.
Thank
I'm
you.
calling you Daniela, so why shouldn't you call me Jack?
Exactly. So, welcome from the bottom of my heart, and it's a real honor. So, before we dive into today's topic, which is induced lactation or relactation, I would like to ask you first, when was that moment in your medical career when you decided you wanted to become a breastfeeding expert? Was there a moment you can recall? Was it a collection of moments? Did it just happen? Can you tell me about this?
Well, I guess I can. My children were all breastfed, and what I found was that there were all sorts of people who had ideas about breastfeeding. I wasn't a pediatrician when it started, but I trained as a pediatrician, and I was very surprised at the attitudes that many pediatricians and pediatric residents had about breastfeeding. This surprised me. I didn't know anything specific about breastfeeding. I just know that my wife was able to breastfeed without any problems, really, and the babies were breastfed for 4 years more or less. Anyway, after that, I decided what I was going to do. I got a job in South Africa in a what they used to call black homeland, and at that time, the I saw that babies really did die if they didn't get breastfed. So I learned some, but not very much. The nurses knew a lot. And then when I came back to Toronto, I worked at an emergency department at the Hospital for Sick Children, and I saw mothers coming to the emergency with problems with their babies that were really breastfeeding problems. And so I decided to start a clinic to help mothers with breastfeeding, and that's how it all started. And then it just got bigger and bigger, and now I do only that.
Wow, wow. What an incredible career and everything that you have done for the breastfeeding world. It's
Oh, well,
really
thank you. That's
amazing.
nice.
Yes. Okay. So, what do you hope is your biggest legacy to the breastfeeding world?
Well, what would I really like? I suppose that people started to learn how important breastfeeding is, how important it is to the health of the child, how important it is to the health of the mother, And this message is not out there. Pediatricians are particularly bad about understanding breastfeeding and how important it is, but they're only slightly worse than most doctors. And there are exceptions, of course. I'm not going to say that everybody is the same, but really the knowledge about breastfeeding and how to prevent problems with breastfeeding, they're just unknown in the
Mhm.
medical system.
I feel like um, the message it's coming about the importance and how it protects and everything. It's just they don't know. They don't
They
know
don't know.
how. That I think it's the biggest problem. Yes.
Exactly.
Okay, so let's dive into our topic. Can you tell us what's the difference, or is there a difference between relactating and induced lactation?
Well, I mean, they are two words that describe a different situation. So if a mother is induced, or a mother, yes, we'll call her a mother now, a mother is inducing lactation, then she probably is not pregnant, or she is adopting a baby, or she has a gestational carrier for her baby, but she is not pregnant herself. So she is inducing lactation so that she can breastfeed her baby who is born to somebody else. Sometimes, not frequently, but sometimes there is the partner of the mother who is inducing lactation uh, also is a woman and is inducing lactation. And we've seen this in this situation. Or perhaps the mother herself is pregnant, but her partner is inducing lactation to be able to help out. So that are the two situations we usually see. On the other hand, a relactation is a situation where a mother was breastfeeding, but for some reason she stopped breastfeeding, usually, unfortunately, for reasons that weren't necessary, and so now she wants to start breastfeeding again. So it's a very different situation. The words just describe that rather than something that's very, very different. So if a mother, was able to be breastfeeding for, say, 2 or 3 months, and then for some reason, often it's medication, you can't breastfeed because you're taking this medication, which is almost never true, then she stopped breastfeeding, she wants to start again, and I think it's very possible to make that work.
Okay. Um, well, first about relactating, what um what things that have happened before in that lactation contribute or make it easier for that mother to successfully relactate and go on to have her full milk supply again, if she ever did have a full milk supply? Are
Hmm.
there
I think
factors that can
the
contribute?
most important factor is whether the baby will still take the breast. Because if the baby is still taking the breast, it's still possible that the baby will take the breast. And sometimes when a mother had a very large milk supply, even if the baby has been off the breast for 2 or 3 weeks, even 2 or 3 months, if the baby will take the breast again, everything is possible. And we have had numerous mothers in that situation that even if the baby was not at the breast for 2 or 3 months, the baby still took the breast. And once the baby took the breast, we could make things happen.
Wow. And if the baby doesn't take the breast, can you do it, or have you done it, or are mothers motivated to do it but with a pump?
Uh, yes, it's possible, of course. And the thing is that, everybody thinks bottles are necessary. But let us say a not an uncommon situation is the baby now is already 4 months old and he won't take the breast. But the baby doesn't need to take the breast, and the baby, at least to begin with,
To
and the
begin.
baby certainly does not need to take bottles. What the
Mhm.
mother can do is express her milk. We can help her increase her milk supply by using a drug called domperidone, which you can get in Mexico without
We're gonna
prescription.
talk about that.
Yes. And at the same time, the mother gives this 4-month-old baby food. She can mix her milk with the food, but if we can get the baby off the bottle, if we can get the baby off the pacifier, then as the mother's milk increases, the baby is more and more likely to take the breast. And so we recommend not only increasing the milk supply, but having the baby skin to skin with the mother as much as possible. So even when she's walking around the house, if she's got like a huipil, no, that's
Uh-huh.
in Guatemala. She has
Yeah,
some
like a
hold the
carrier,
yeah.
but
She
depending on
keeps the
the
baby
age.
right next to her. She
Exactly.
sleeps with the baby side by
Mhm.
side at night. Then even there, it's possible to get going.
Exactly.
So it's
Like you do it
possible.
by stages. Like if the mother doesn't have a good milk supply, you can, what you're saying is you help her build it,
Increase it. Yeah.
increase it, and then, well, all these, you know, tips, I guess, I don't know the word,
Yeah,
to
that's the
make
word.
the baby come back to the breast. And
Right.
once,
So yeah.
once,
So,
uh-huh,
stopping bottles and pacifiers is very important.
yes.
And so as long as the baby is not getting a bottle or pacifier and the baby is close to the mother and there's something about remembering being there,
Yeah.
then it's quite
It,
possible for this
it's
to
his
happen.
happy place.
Yeah, exactly.
The
So the
happy place.
baby gets fed. You can't starve
Mhm.
the baby, but instead of giving in the 4-month-old, say, or even younger, we've done
Mhm.
this with 3-month-old babies too. But at 4 months, typically everybody says, oh, you can start solids at 4 months. Yeah, you can. We don't usually recommend that. We usually
Yes.
recommend the WHO approach at 6 months, more or less. But if the baby is 4 months old, the baby can eat. The baby doesn't have to take a bottle. The baby doesn't have to take the breast yet. So you can feed the baby and increase the milk supply and keep the baby where the baby's happy.
So, what's the percentage of mothers who can actually manage to relactate and have full milk supplies? Do you have that statistics about this?
No, because we don't have that many requests for it. So based
Okay.
on our patient population, I would say that it depends. I mean, you have to be willing to put in the work, and it's not always easy. So I think that I don't know. I would say that 50% get the baby back to the breast, maybe
Okay.
more.
So talk to
But
me.
no,
Go
I was
ahead.
just going to say, but they can still breastfeed and supplement. And
Uh-huh.
again, depending on the age of the baby. But we would usually recommend if the baby needs to be supplemented using the lactation aid at the breast. So like a
Yes.
tube with
A
milk. Okay.
relactator.
Yeah.
Uh-huh. Yeah, because I've heard you say that even though it is rarely appreciated, I know about that too. The act of breastfeeding is much more than feeding. So that is why I think, or I wanna know what you think, is why many women, even though they may not go on and have full milk supplies, and also in induced lactation, um, is that why many women, what do you think that's the motivation, the first motivation that they have, like that, that closeness, the experience, the bonding, everything about breastfeeding, that is not just the milk?
Yeah, I don't know. I mean, sometimes it is the fact that they've heard that breast milk is so much better than formula for the baby. In some cases, formula is very expensive for people, and so there's that issue. But yes, I think that a lot of mothers do it because they just love the experience of breastfeeding. They love the closeness of breastfeeding, and they love that special relationship between the mother and the baby. That you know, even if like my children, they were breastfed for 4 years, they stop eventually, and
Yes,
it
they
and
will
the mother
stop.
sometimes
Exactly.
feels she's lost something,
Yes,
but
yes.
they grow up. It's part of being a parent, right?
There's a grief always. I mean, even if you breastfed until 4 years and the baby weaned alone,
Hmm.
you're still gonna feel some grief. How important is motivation for the mother to go through these processes? What does it imply? Does she have to, to work, or I mean, is it does it require from her effort, like physically and emotionally? Talk to us about this.
Yeah, I think physically, yes, because if they're pumping, and many of these mothers to relactate are pumping, yes, it takes work. And of course, it's emotional as well, because maybe the baby doesn't take the breast right away. And so the mother is, upset. Or
Yes.
maybe the baby takes the breast at night, but not during the day.
Yeah,
And
typical.
so, the baby cries and the mother is upset. And maybe her partner is not very supportive because that's an issue often a lot of the time, and the father wants to feed the baby and so feels that she is trying to cut him out. She's not trying to cut him out. She's trying to maintain the relationship with the baby. But fathers don't always see that. And so, uh, we really need to get this message across that breastfeeding is more than just milk, and that, hey, dad, you'll be able to feed the baby. Wait, oh, I'm giving the baby some food, some solid food. So here, go ahead.
And then also there are other ways to interact with the baby. I mean, the father
Sure.
can do skin to skin, and he can bathe the baby and sleep the baby. I mean,
Hmm.
everything but that. So,
Right. And often though, if, oh no, I just want to feed the baby, you bathe the baby, is because he's jealous. So
okay.
yes, it's true. Why there are lots of things that the father can do, and if he doesn't want to do these lots of things, but only wants to feed the baby, then it's something
You
to
should
worry about.
you should get to a root of that. Okay. I want to talk about induced lactation,
Okay.
which I know it's more difficult. Well, I think I want you to tell us about this. Um, how does it look? What do you normally do with these mothers when they come to you and say, I want to induce a lactation, but I'm
Hmm.
not pregnant?
Yes, yes,
Um,
of course.
how's the protocol for that?
So generally, we try to mimic pregnancy in this woman. And so, what do we see in pregnancy? We see high levels of estrogen, well, high compared to non-pregnant, high levels of estrogen, high levels of uh, progesterone, and
Mhm.
high levels of prolactin. And we can mimic that with the birth control pill, which we generally say it's important that there's a higher level of, high levels of progesterone rather than, average, but I don't think it matters that much. Plus, we put the mothers on domperidone, and we would
At
like
the
the
same
mothers to,
time, I mean, with
yep,
birth control? Okay.
yep.
Okay.
So we mimic what goes on in pregnancy: high prolactin, high estrogen, high progesterone. Now, there are other hormones that are involved and that we
Mhm.
can't give to the mothers because, first of all, they require injections, usually injections on a daily basis, and it's extremely expensive. So
Okay.
we can't really do that, and possibly that's why we can't completely make sure that every mother can produce all the milk the baby needs.
Okay.
We would like the mothers to be on this regimen, the birth control without a break, no placebo pills. So they go
Okay.
1 2 days, because that's what happens in pregnancy. You always have high
Exactly.
levels. And so we would like them to be on that for at least 4 months. Why 4 months? Because when you fall pregnant, you start producing milk around 16 weeks
Hmm.
after implantation. So I don't know. We made that up, but it seems reasonable, and we want the mothers to be on this regimen for at least that long a period of time, and then after when the baby is due, say in 6 to 8 weeks, we say stop the birth control pill, just like that.
Hmm.
All the, you'll have a
Just like
bleeding,
if the placenta was coming out of the body.
right? So you get the
Hmm.
bleeding, but you stay on the domperidone, and
Exactly.
then when the mother can get the baby, and the sooner the better. In Ontario, where I live, in Canada, they can be in the delivery room, and they can take the baby right away.
Oh,
In some
wow.
places in the United States, for example, they have to go through a whole rigmarole. They have to wait, 3 4 weeks before it's okay. This is a problem. But
Mhm.
if the mother who was pregnant will feed the baby at the breast, it's good for her because it'll prevent her from getting engorged, or it should if the baby's breastfeeding well. It'll
Mhm.
prevent her from getting engorged. The baby will get the pregnant woman's colostrum, and then as soon as possible, pass the baby on to the mother who is adopting the baby. So there may be a period where she's not doing it, although we've had a fair number of mothers who said, okay, until you get the baby, I'll breastfeed the baby. and that's good for the
Okay.
baby. It's good for the mother who was pregnant, and it's good for the mother who will be breastfeeding. So
Okay.
that's basically the approach.
When
It's
she
not
when she
very
stops
complicated.
when she stops the birth pill and stays on the peridone, does she start pumping at that stage?
She starts pumping, yes, when she stops the birth control pill.
Okay.
So, and again, it may depend how frequently, it may depend on whether she's working outside the home or whether
Okay.
she's home. So,
And how she's
she can,
responding, maybe?
right, she may try breastfeeding, pumping more often or less often if she's getting tons of milk. And we've had a number of mothers who breastfed exclusively
Wow.
after inducing lactation.
Do you
But
have like a percentage in your mind about how many?
I don't, because
No.
we just haven't had enough that
Okay.
not I mean, I get this information on the I get emails about this all the time. So there are mothers that are inducing lactation all over the
The
world
world.
who are
Yes.
contacting me, but the ones that we can really verify, because they come to our clinic and we watch them breastfeed once the baby is born, I would say about 50% get a full supply.
Wow. It's incredible.
Well, I'm not sure of that.
Okay. Yes. Is this protocol, all of these that you're explaining to us, something your clinic pioneered?
I pioneered this uh, with a woman, lactation consultant in Montreal, Lenore Goldfarb,
Okay.
and she made up these, there was a special protocol for this situation. There was a special protocol if the mother was postmenopausal, and there was a special protocol uh, that she called accelerated. But I think that this is all unnecessary and very complicated and really isn't necessary. And we don't do that anymore. It doesn't matter the age of the mother. It doesn't matter whether she's, going
It
through.
doesn't matter if she's postmenopausal.
Sure, go ahead. Yeah, yeah.
Wow.
There's at least one of the patients I've seen uh, actually did this from our protocol, but she didn't contact us. She just did it. And then when the baby was 6 months, she came to the clinic and told me about it. She was breastfeeding exclusively, and she was 49, I think. She was definitely
Wow.
postmenopausal. And the
Wow.
reason she came is because the father, her husband, said that she had breastfed long enough. The baby was already 6 months. So,
Yeah. Okay. So what should the healthcare team leading this protocol look like?
well, we have in our clinic, we have a pediatrician, and we have several. We have four pediatricians that work there. So all of them basically know how this works. But it's really the lactation consultants in our clinic who do the, work with the mothers.
Okay.
And I think that's fair. They know more than the pediatricians about, the real hands-on breastfeeding.
Yeah.
So, okay, I have no problem with that.
Okay.
And so that's our team. And of course, we have office staff and you know that sort of thing.
Okay. Yeah, because I'm thinking like right now, if somebody comes to me and says, I want to induce a lactation, it's really complicated to get a doctor to work with, since you have to
Uh,
use medicine, yes, that knows about this. So I hope what we're talking about here really contributes and opens the curiosity of physicians to look at this and to look
yes, I
at the
hope so.
work that
But
has been
pediatricians,
done.
sorry,
Mhm.
yeah, physicians in general have no problem prescribing the birth control pill.
Yes. That's true. Yes.
And of course, the domperidone is available in Mexico without a prescription, so that makes it easy. In the United States, it's
Yeah.
very, very difficult to get domperidone.
It's
I
very, very
tell,
difficult.
sorry, yeah.
Why is that?
Oh, I
Is
don't know.
It's because, I mean, the evidence. Okay, so talk to me about domperidone. I
Oh,
know that you use sometimes, depending on the case, I guess.
we use it a lot.
Okay, high doses. Okay,
Yeah.
so I want to talk about doses, if that's okay, and
Sure.
know if you do labs at your clinic or specific studies to mothers to make sure it is okay for them to be in such high doses. Do you see side effects commonly? Which ones? For how long can they take this medicine? Talk to me about this.
Okay. Well, they're not such high doses. Uh, such doses were being used for in gastrointestinal departments in Toronto. They were using doses like that to treat people who had gastrointestinal problems uh, Crohn's disease or ulcerative colitis. I'm not too sure exactly the reason they were using them for them, but they were using such doses as 120 milligrams a day. So it's not such a high dose. We usually start with 9 tablets a day, and I think anything less than that really does not work well.
9 tablets, how many milligrams is
Oh,
that?
that's they're all there's only 10 milligram
10,
tablets.
10 milligrams, right?
Yeah,
Okay.
they don't there's no 10, 15, 20. It's just 10.
Well, there's one in Mexico which I didn't know about that has 60 milligrams. Um,
60 milligrams.
but I think it's released like
Slow release.
slowly.
Okay.
Uh-huh.
Well, slow release might be better in a way.
Okay.
But we would still use 60 milligrams twice a day, for example, in some mothers.
Okay. So it's 90 milligrams we're talking about.
Sorry, 120.
90 milligrams?
90 milligrams what we usually recommend to start with. We want to use the
Wow.
smallest dose that works and gives fewer side effects. Okay, so
Uh-huh.
if the mother's
I
taking
mean,
90,
I'm finding this really interesting that you're telling me it's not too big of a dose. When sometimes domperidone is wildly used. I mean, it's
Mhm.
but it's only 10 milligrams 3 times a day, so it's 30 milligrams. So when in some cases you know that the dose should be higher, like let's
Absolutely.
say 60 milligrams, it's commonly a problem that the doctor says yes. So that's why I'm, to get you in perspective of how it is seen and managed, at least here in Mexico. So, okay, go ahead.
Well, I mean, basically, I think that if first of all, 10 milligrams 3 times a day, you might as well just throw it in the ocean. It's not worth it. I think that if the mother
Okay.
gets better on 10 milligrams 3 times a day, it probably means that she didn't need it in the first place. And
Okay.
we use domperidone not just here's the domperidone. We help the mother latch the baby on well. We teach the mother
Mm,
how to know the baby's getting milk from the breast. We teach the mother breast compressions, which is like pumping into the baby the milk. We make sure that they offer both breasts at each feeding because mothers are being told you should feed the baby on just one breast at a feeding. I don't know where this comes from. It's
well,
just not
the
normal.
Academy for no, you know what I think. What I think is that mothers have this idea that they have to interrupt so that the baby can get the milk from the other side. But if you really leave the baby just on demand, the baby's gonna fall asleep in the first breast. Without being interrupted. And then, like in about 3 minutes, he's going to start moving again and he's going to go
Mhm.
to the other breast. If it's
Right,
not in 3 minutes, it's going to happen in 8 minutes, you know?
right.
So
But mothers,
it is going to happen. The baby usually takes the other breast. It's not going to be 2, 3 hours since, uh, uh, 2, 3 hours until the baby gets the other breast. So he usually does get the other breast. It's just not that you have to interrupt, count in the minutes, and then get the baby to the other breast. So I think it
right,
has to
right,
do with
right,
that interpretation. Yes.
right. Exactly. Well, I think that the some of the mothers that just give one breast, then the baby gets like the Italians say here, and choo-choo, they get a pacifier. But they really want
Okay.
the other side.
Okay. So going back to amperidone, have you seen side effects commonly? Which ones?
We see side effects very uncommonly, but the most common side effects are usually in the first week. Headache, which is usually quite mild and goes away all by itself. You don't need to take anything for it, or you don't have to stop the domperidone. But I mean, if it's worse than the average, then take something for the headache. Uh, we also see dry mouth. We see basically some abdominal cramps, but these things all go away all by themselves. You don't need any treatment for it.
And do you do any? Because I don't know what you think, but I've heard that it can give the mother some. I don't know. I don't have the word like
An
cardiac
arrhythmia.
an arrhythmia. Exactly. Is that true? Do you do any labs or any
No, we don't do any labs unless the mother is already on some medication that causes problems with the
Okay.
QT interval. It's part of the electrocardiogram. It's very
Okay.
uncommon. 1 in 10,000 people has it, and
Okay.
it's
So
much less.
so that's a side effect. That's a
It's
very
serious,
rare side effect.
serious, yes,
Yeah, serious but rare.
but rare. And so, if there's any reason to be concerned, like a strong family history of sudden unexpected death, then the doctor should do an electrocardiogram. But there are many drugs that do the same thing, but nobody ever worries about it.
Exactly. Yes.
So they get, like for example, some antibiotics. People use it all the time. They don't do an electrocardiogram. Uh,
Okay.
the major tranquilizers like Prozac can
Okay.
cause the same problem, but nobody does an electrocardiogram.
Nobody. Yes. Okay. And so, oh, I wanted to make another question and it went away. Okay. Oh, I know what it is. When you start with these doses, do you start with lower doses and then like go up? No,
No,
just
we start
straight.
with 30 milligrams 3 times a day.
And you don't win the dose also. You just cut it when it's time.
No, 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 no. When you're ready to stop, and
Uh-huh.
we usually recommend that if the mother is taking it for a decreased milk supply, to make sure that the baby is eating lots of food and then start weaning, but wean slowly. So if you take 9 pills a day, it'll take you 9 weeks to stop the medication. So you drop a pill every week. So you start with 3 tablets 3 times a day. The next week, when you're ready to wean the baby yourself off the domperidone, then you take 8 pills a day for a week, and then the next week 7, etc., until you're off. So in that way, you don't get these things you can read on the internet about being, having sleeplessness and anxiety and that sort of thing. It's not domperidone that causes these side effects. It's going off the domperidone too quickly that causes these side effects. But that's not what's on the internet. The internet
Okay.
tells all sorts of horror stories about
Yeah,
domperidone.
you don't have a context for what the side effects are listed. So the average woman that you have had on domperidone in these doses, for how long has taken this medicine?
Oh, okay. So many take it until the baby's 7, 8 months, 9 months,
Okay, so
maybe.
it's a long time.
Okay. Oh, some are still on it. The baby's 3 years old. And sometimes, if the problem is the baby's not latching on, then and the mother's producing lots of milk. But when we have a baby who's refusing the breast, we'll often put the mother on domperidone, even if she's able to express all the milk the baby wants. Why? Because the more milk there is, the faster the flow of milk, the more likely the baby to latch on.
Exactly, yes.
And in that case, once the baby is well established breastfeeding, there's no more worry the baby will refuse the breast, then we can stop the domperidone, and it doesn't have to be so slow, right? Because she's
Okay,
often only been on the domperidone for maybe 2 3 weeks. It's not the same as
exactly.
being on the domperidone for 5 months,
Well, of course, every case has to be individualized, right?
right? But I
Like to
think too
say
many
what
mothers want to stop the domperidone too quickly. In our cases, because they've gone to the internet and they're very scared. And there's no
exactly.
reason to be scared. It's a safe drug.
Yeah, I remember another story from that Congress was that I asked you, I got the microphone and I asked you, Dr. Newman, what do you think about the side effects? And you replied to me, what side effects? I
That's true. They're
remember.
not very common.
Yes,
But it's not true. There's no such thing as a drug that doesn't have side effects.
exactly. I mean, every drug has a side effects. Exactly,
Possible.
that's true.
Yeah.
Exactly. So these are all the questions I have about our topic. Do you want to say something else about this, about the
Uh,
topic?
About the topic specifically, I don't think so. I think we've pretty well covered it. But I think that, remember, not every mother who induces lactation, for example, will
Yeah,
produce all the milk the baby needs. And I think that
exactly.
the thing to remember is that breastfeeding is so much more than breast milk. In fact, a lactation consultant in Europe told me about a mother who had bilateral mastectomies for breast cancer, and she still breastfed her baby
Exactly.
with the lactation aid.
Yes. I mean, I mean, what you're saying is so very important, not just for someone that wants to induce or relactate or um, that is worried she's not going to have a full milk supply. It's it's basic for every woman that wants to breastfeed. Period. Because when you don't understand this, then you can't really get the dynamic it's going to be like. When you have the baby at the breast and how the baby behaves and how he wants and why he wants to take the breast and why he wants to be in this human closeness. You don't get it, and so
That's right.
you start seeing problems when there are no problems, and they start to worry when they don't have to worry, and start to try to do all sorts of things
Yeah.
which are going to bring problems. So I mean, I think it's very important what you say, and I like to talk very much about this too, because of that. Because I mean, everyone who wants to breastfeed should understand that part.
Hmm.
Definitely.
Yeah, I think that too many people have one too high expectations, but at the same time, they have to know that that many of the problems that mothers are having with breastfeeding can be prevented, and if they come around, if they come up, they can be treated. In other words, it's not normal to have sore nipples. And so if a mother has sore nipples, she should seek good help as soon as possible after the baby is born. Because if you wait 3, 5, 6 weeks, then it becomes much harder. And I think that this is very important. But one thing I need to throw in right here is that the answer for sore nipples is not a nipple shield. I am so
Right.
against nipple shields.
Me too.
It's terrible. I think they should be
Me
banned.
too. Yes, me too. It has many risks, really,
Yeah.
and I mean, it's not really indicated for treating sore nipples.
No,
So
and it's not
it
treated for the
doesn't make
baby who's
any
not
sense.
latching on, and it's not indicated
Yes,
for anything as far as I'm concerned. The
yes,
one thing I
yes. I
hear from
agree
some
with you.
lactation consultants is, well, it encourages the mother to keep trying. No, it doesn't. The
No,
baby will stay on the nipple shield and the milk supply will decrease, and the mother will never, well, no, I shouldn't say never, but will have a lot of difficulty to get the baby off the nipple shield. And again,
I
the longer the
agree
baby's on the nipple shield, the
a
worse it is.
hundred percent. 100%.
Good.
I don't like nipple shields. Yes.
Uh,
I've
Estamos de
used them
acuerdo.
sometimes, but really not for this.
Yeah.
The only times, because my style, I try to be very respectful of what the mother wants, and so I always say, I'm not going to say don't do it or go do it. I'm just going to say these are the risks. Let me explain to you why, or what are the risks about doing this, and then you can decide if you want to take those risks. And very recently, a mother who was having problems told me, you know what? I know everything that you have told me, everything, but I want to try. And I said, okay, so you know what you're getting into. So,
Well,
but yes,
but
I
most mothers are
agree.
using it because, oh, your baby is, you got sore nipples, in the hospital. Baby's 1 day old.
In
Here's
the
a nipple.
hospital, yes, all the time. And in the babies list, the lists that the mothers have before the baby is born, like, buy some pajamas and then buy nipple shields. And I always say, why? What's a nipple shield doing there? I mean,
Exactly.
and always saying, if you think you have to use a nipple shield, please make it under supervised, specialized lactation care. I mean, just don't just throw it in
Yeah.
there.
But a,
Yeah,
but
I
a good
agree.
lactation consultant managed to get the baby not to take the nipple shield.
Exactly. Yes, I agree.
Okay, good.
So let's go to the ending personal questions to get to know you a little better. What book has inspired you or left you an important message?
Um, that has to do with breastfeeding or just any book?
No, anything. Doesn't have to be breastfeeding.
Well, the one that comes to mind, because I talked about it recently, but I haven't read it for a long time. It's called The Trial by Franz Kafka. And you know the book? No?
No, but I know Kafka. Well, I
Kafka?
haven't read him in a long time, but I really like him.
Yeah, I know. Well, I haven't read this book for probably 40 years, but it left a strong, strong impression on me. And I think that we see this more and more in our society where, you have a problem, you try to get help with the problem, and you just go through a whole rigmarole and here this, fill in this form. Okay, no, that's not the right form. Here's the right form. Oh, you're going to have to speak with so and so is away on vacation, and so serious problems are put off, put off, put off, and you're trapped in this maze, and you can't get out of it. That's Kafka.
Yeah. Yeah, I don't think it's the same book. I'm not sure if I'm gonna translate it well. I think the one I read was called The Metamorphosis, but
Yes, 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 yes.
yes,
Where the man
yes,
wakes up as an insect.
yes,
So
exactly.
you see what kind of a mind this Kafka had.
Yes. Interesting.
Yeah.
Interesting, yes. So, how do you see the future of breastfeeding?
Well, I think that given the situation that we have in the world today with global warming or global crisis or global catastrophe, as well as things like COVID, I think that it's going to come back because in a way that it hasn't come back for a long, long time. Because people will start to realize the making of formula is a whole anti uh, it contributes to the climate crisis
Yes,
and in a very
exactly.
big way, because if you think of all the cows that are out there and what they're doing, and the travel of the milk to a factory, they make it in a factory and then it's distributed, people are going to realize that it's a major problem. And the same for pandemics. We'll finally realize that breastfeeding is what protects the babies most, despite what the Center for Disease Control in the United States said, that the mothers and babies should be separated. That's terrible. They did
That's
change their
terrible.
minds,
Hmm.
but not before the damage was done.
Exactly. Yes, and I mean, there are countries in which we still have to work a lot on that because, like, routinely, babies and mothers are separated.
Oh,
You have to have a, yes, you have to have a good pediatrician that knows that that's not the
it's
right
not
thing to
good.
do and that stays with the mother and everything. But if
Yeah.
the mother doesn't ask for anything and the pediatrician, it's not very actualized, I don't
Knowledgeable.
know. Yeah, exactly, then they're going to be separated, even though it's full term
That's
and
not what the WHO says. They talk about the magic
exactly.
hour.
Exactly, yes. But well, we're working on that.
Okay, good.
So what makes you want to cry of joy, of pure positive emotion?
Oh, when you're talking in respect to breastfeeding.
Well, breastfeeding and not breastfeeding, I mean, these
Oh,
questions are personal, so you can say
oh,
whatever you
okay.
want.
Well, I mean, uh, to be in love. That's the best
Uh-huh.
there is. Okay, sure. That makes me
Yes,
cry for joy.
yes.
As far as breastfeeding is concerned, I think that when I receive an email from a mother who says, "Oh, I didn't think I would be able to succeed, and the
Hmm.
information you sent me, and everything is fine now and great," and that's good for crying,
It's good for crying.
laughing for
Yes,
joy. Yes.
yes. Oh, Dr. Jack Newman, Dr. Jack, thank you. makes me want to cry of joy
Okay,
and
that's
positive
good.
emotion.
Oh, wonderful.
This interview and this interaction and this connection. I really, I'm I sometimes say I'm a little bit intense, and then I go and say, well, I'm a little bit overly enthusiastic.
That's it.
So
That's good.
I really get excited. I'm very passionate about this, and I hope someday to you know, to well to serve from my little world just a little bit such as you have. So before we go, please let us know how can people listening to this can contact you, your clinic, workbooks, everything so wonderful that you do. We're gonna put everything in the episode's notes.
Okay, so we have a website, ibconline.ca.
Okay.
Okay, and we have blogs there. We also have information sheets, but the information sheets are getting old, and I think we need to revise them. But we have blogs which are relatively new within the last couple of years. We have them in English, but we don't have them in Spanish. We have them in French. We have a pediatrician in Brazil who's translating them into Portuguese. And we have a few, one or two in Italian, one or two in, yeah, but
Oh, that's great.
Spanish we don't have. So
Spanish we don't have, so
we need
this
a
is a shout
trained
out.
translator.
Who wants to
Oh,
translate them?
yes, yes, but it has to be somebody who's trained in translation because speaking two
Yes.
languages fluently is not
Not
always
enough.
good
Yeah.
enough.
And it's not good enough. That's right. I know. So, Dr. Jack Newman, thank you. Thank you, Jack. It was a
Gracias y
great
mucho
conversation.
gusto.
I
Yeah.
think I mean, it's incredible information, what we talked about, the protocols you have, and all you're doing at your clinic. So,
And by the way,
hopefully,
there is a blog on our website on relactation and on induced lactation. They're
oh,
separate.
great. Okay, so I'm going to put everything in the
Okay.
episode's notes so people can access it with ease.
Okay.
So, thank
And
you
if
very
they
much.
thank you, mucho gusto, que le vaya bien, and maybe another time. Okay. Ciao.